Good evening, friends. It is it again a very great pleasure for me to meet all of you this evening for yet another edition of the IAGES Prime Time. You all know, and for the benefit of the new watchers, IAGES Prime Time is a brand new program which has been happening over the last 2 months, where we have two components. One is to interview a pioneering legend who has dedicated his entire career for a development of a specialty or a development of a particular surgery. And we also get to hear to pioneers who have been working on a single procedure for their entire lifetime. It has been a rocking week last week with the great conglomeration of the IAGES and the RCS Edinburgh for having a phenomenal midterm virtual congress with more than 2,000 participants and 300 faculty. So I'm sure all of you would have cherished the moments staying with us. Now let us hear to two important luminaries for this week. The first half of the session is going to be none other than the father of endocrine surgery and the man who created the field of surgical endocrinology in this part of the world, Professor S. Vittal. Professor S. Vittal will be interviewed by none other than our Honorary Secretary, Dr. S. Ishwarmurthy, sir. Followed by, we have a very important person in the global arena, Professor David Watson. Professor David Watson has done individually more than 4,000 anti-reflux operations. And he is going to be reminiscing with our President-elect, Professor D. Sunil Papat. So, ladies and gentlemen, I present Professor S. Vittal along with Dr. S. Ishwarmurthy. Over to you, Nitin.
Friends, ladies and gentlemen, welcome to IAGES Prime Time. 8 decades ago, there's a little town called Tiruvallur near Chennai, born a surgeon who, with the sheer determination and hard work, became an integral part of history of surgery in India. A pious, iconic surgeon with wit and wisdom in his speech and precision of execution in every action. He has made a lasting impact in whatever he did and wherever he went. He is a fatherly figure for all of us, and he is the father of endocrine surgery in India. Yes, this is our one and only Professor Dr. Sripadam Vittal from Chennai, whose story I'm sure will be a great inspiration for all the young budding surgeons. Please come with me. Let us go to his house to meet him and greet him.
Hello, sir.
Yeah.
A nice meeting you, sir. This is from IAGES office. As a secretary, I'm very, very glad to meet you today. And today you are going to be in the IAGES Prime Time, wherein people across the country or even various parts of the world are waiting for us to show the living legend. So nice meeting you after some time. And I wanted you to remember those days when you had your undergraduation, post-graduation, and as a passionate teacher and assistant working in the corridor of Madras Medical College alongside Professor Sara Chandra, those days of your undergraduation, post-graduation, sir.
Thank you, Dr. Ishwarmurthy, for inviting me to be in the midst of IAGES Prime Time, for which I'm very much honored. In fact, my mother's father is a very famous doctor those days, Dr. G. Narayan Sam Madaliar, and is a contemporary of Dr. M.R. Gursam Madaliar, Colonel Pandalai, and other things. My mother always used to talk very high about the father. Father did that as a doctor, he did that. So in my growing period itself, I felt that the doctor profession is something which you can do something good for the people, and that is how I got interested to become a doctor, and that's how I entered into medicine. And those days, there are only 3 medical colleges. It will be Madras Medical College, Stanley Medical College, Madurai Medical College, only 3. And about 300 students only will be taken. So we had a very cohesive relationship in the Madras Medical College of working under a great doyen of yesteryears, Professor M.M. Cooper.
Yes, sir.
M.M. Cooper is a very great anatomist. And I started developing interest in anatomy. I started reading lots of anatomy. And those days, and I used to like anatomy because of Cooper. After I entered into my postgraduate, I was with the Professor G. Atmarama Rao, an army returned surgeon who came from Vizag and joined the Madras Medical College, along with Padma Shri, Professor Sadashivam. They are all there. Colonel Shepherd, they are all there. They came and joined. I was with Atmarama Rao, who is known for his punctuality, time, and a very neat person. I was very fortunate to be with Atmarama Rao, and he taught me how to behave with the patient. He is very particular. If you go and examine a patient without even putting a towel, you had it. Simply you had it. The decency of examining a patient.
Bedside manners, all
Manners,
those things. People say in UK it is a very important aspect in your assessment also.
Yeah.
I think you learned it here itself in
Here
India.
itself.
You were blessed with the good mentors and the teachers.
Very many mentors.
I mean, I'm sure because I was told, and also I heard fortunate enough, I was listening to your mentors, Professor Sara Chandra, I am sure, along with him. This is a very important occasion I could see.
Correct.
Could you just recollect this important occasion and about this genius whom you had the fortunate to work with, and please tell us about him, sir.
This is Professor Sara Chandra standing there, and the person who is lighting is the Dean of the Madras Medical College, Dr. V. Sivarajan, and his RMO. And in between, I am standing. This is the beginning of the division of surgical endocrinology, and it was started like that. Professor Sara Chandra and myself, and of course with my colleagues, junior colleagues like Rajesa Bhavati and others, we have brought out a book on surgical endocrinology with invited contributions. And that is the release of the book that you are seeing that. And that is another an epoch-making event. As far as I am concerned, it's a very, very important thing for me. As far as I am concerned, that is my view. I'm yet to see a person with abundance of knowledge. He will talk about blood pressure. Suddenly he'll say, do you know what is law of Laplace? He will talk to physics. And something like that. He's a walking, we call him a walking encyclopedia. And he's such a great teacher. And second quality is unassuming. Once for the sake of my juniors, I want to tell one incident with Professor Sara Chandra in the unit. One patient, some postgraduate has operated. GJ, those days they used to do GJ with vagotomy. And it started oozing. And the nurse called for the DAS. DAS was not available. I was busy elsewhere. So she rang up Dr. Sara Chandra. Dr. Sara Chandra came immediately at 9:30 and he needed blood. So there wasn't anybody. So he went along with the nurse to get the blood, and he gave the blood and went home. Next day rounds, he was asking, how is this patient? The same postgraduate said, he's all right, sir. Any problem? No problem, sir, he said. And we are all feeling very bad. Professor Sara Chandra himself has come and given the blood, and this fellow, he says, no problem. He didn't say, don't lie, and nothing like that. Such a great personality. I am yet to see like a person like Professor Sara Chandra. Is a very, very, very simple man. And he allowed me to teach night and day. And that is how I picked up his qualities. Because, you go on with a person forever. and you pick it up. So that's a very great personality.
Can you tell me about this person in the ward round along with you in MMC?
I can never forget this personality. He's again another person who helped me to go up on the ladders, particularly in Britain. He is Professor John Fondon. He's a professor of surgery at Bristol. Whenever I go to Britain, I used to get down at London and go to Bristol to visit Fondon, and he'll pick me up and be with him and drop me back. And whenever he crosses Chennai, he'll get down at Chennai airport and he will come and visit my ward and make ward rounds, teach the medical students, and such a gentleman to the core. John Fondon, such a knowledgeable person, and he used to talk to me on the phone, and he made me as one of the members of the editorial board of British Journal of Surgery. So he always say, you are fit enough to become a editorial board of British Journal of Surgery.
Only last week with Mike Griffin came virtually, and he was very happy the way we arranged the IAGES, and the Indo-UK Surgicon is essentially a exchange of knowledge between Royal College of Edinburgh. These are all possible because of people like you worked for several decades.
Well, I think I will say at the first instance, I was not staying for too many years. About 2.5 years, I would have stayed there. That's all. Because what happened when I went in January or February, I got my primary. April, I got my final. And I joined Mr. Gibson at the Leeds General Infirmary. And then later on, I moved on to Wakefield, Pinderfields Hospital. And there I got very much close to Mr. Gibson. And he used to guide me, do this, do that, do like that, And so I became very close to the Royal College. And he was a vice president of those years. So he used to induct me into some of the activities of the Royal College, which I liked very much. I liked the Royal College very much because of its transparency, affection, and they showed on me. I was very much attached to Royal College those days itself.
This is actually one of these main incidents I wanted you to share your happy moments. Overseas gold medal awarded in the Royal College of Surgeons of Edinburgh in 2005, sir. Can you see this picture?
Yeah. That is another memorable thing for me. It is one of the 2005, you said correctly, and quincentenary celebrations of the Royal College of Surgeons of Edinburgh. And they gave for 3 people. And I was very, very happy. How could anybody be not happy? In the world, they have chosen 3 people. And I am one of them. And the president is giving me the medal. And the Pradeep Datta, the honorary secretary, is looking up. And it's really a memorable, this one, overseas gold medal. And I cherish that moment even today. And this is another thing. Very recently in 2010, the English College invited me and awarded the Royal College of Surgeons fellowship. Again, that is another thing. So many things happen between myself and the Royal Colleges.
I think I need to get some of your students to say something about you and what they learned from you. And I am sure there is an endless list of your postgraduate trainees and youngsters. And one of them, obviously, is Dr. Vijay Shankar. You know about Vijay Shankar, I'm sure. He is at Apollo now, Professor Sadasivam's son. I think Sadasivam was your teacher, and now you are teaching Vijay Shankar. So he was so excited. And I'd asked him, why don't you just say a few words, sir?
Good evening, everybody. It's an honor and privilege to talk about a great institution called Professor Vittal, an acknowledged father of endocrine surgery in our country. As a single surgeon, he has done more than 15,000 endocrine surgeries, a number which many endocrine sectors in the world has not done till date. a singular feat and accomplishment for a single surgeon. By his tireless efforts, surgical skills, and innovation in the early 80s and 90s, he made sure that the rest of the Indian medical community take notice of his young, fledgling endocrine surgery center in the Government General Hospital, Madras Medical College. As a result, many patients from different parts of our country flock to his center for good and sound surgery. Padma Shri Professor Vittal is a multifaceted person, a tough taskmaster, an endearing doctor to his patients, and an iconic medical teacher with a slice of British humor which he acquired during his stint in the United Kingdom. As years rolled by, his reputation spread throughout the country. He was soon a nationally recognized endocrine surgeon and a great medical statesman. It was not surprising that governments and head of the governments leaned on him for advice related to medical matters and the diseases of endocrine glands. Some of his words of wisdom were remarkably sharp, witty, and crisp. சில டைம்ல பிரமிக்க வைக்கும், சில டைம்ல சிரிப்பையும் உண்டாக்கும். On one occasion, his young associate brought a few scissors and told him, "This scissor is from Japan, please buy it." He, in his usual pragmatic, humorous way, told him, "Doctor, I don't mind whether the cat is black or white, as long as it can catch the mice in my house. So give me a scissors which can cut when I want it to cut." Thus ended a conversation with a mild amount of wit. His advice to aspiring young medical doctor is 3 important words: read, read, read. In medicine, knowledge is power, not money. Thank you.
Your words after hearing this, what do you want to share? I'm sure.
Vijay Shankar is the son of great surgeon, Padma Shri Professor Sadasivam. Naturally, the genes have come.
Yes.
And now in Apollo, he is one of the very noted cardiac surgeon, which I am very proud of. The teacher is more happier than the taught. So in that way, I always love Vijay Shankar, because whenever he does a great surgery and cardiac cases, he'll tell me I had done that. Well, I am very happy that Vijay Shankar is growing up like anything, and I wish him many more laurels. This is what the teacher should do. Teacher should act like a ladder, and he must lift students to greater heights by showing his own behavior and his own knowledge, his own this one. I always tell my patients or that my junior doctors when they're around, the 3 things that is important. One is availability of doctor. The next is affability of a doctor. Third is the ability of doctor.
Yes.
So when a patient comes to you, you must be available. When he sir, means you must be available. Affability, you should not go and yell, "What do you want?" I say, "No. What do you want?" Like that. Kind words. Last is your ability. How you operate in the theater, the patient is not going to come and see. So these are all the words that I tell like that I go on telling my youngsters. And one such great soul. Now I am happy to see Vijay Shankar talking so nicely in few words about. Thank you very much.
Thank you. And one similar person, I think he is also your undergraduate student, Amarendra. He is now well settled in UK.
It gives me great pleasure to say a few words about our dear Professor Vittal. I knew him for more than 45 years. I first met him when I started my surgical posting as a 3rd-year clinical student at Madras Medical College in the surgical ward at Government General Hospital. He's a kind person, he's a good teacher and a great mentor to his students and postgraduates, including myself. One can learn a lot about surgical pathology and management plan, even while observing in theater, not necessarily only in the wards. He can also pick up surgical skills, not necessarily while assisting, even as an observer in the theater. He keeps the mood alive, and everybody likes his presence and feel at ease. I learned a lot from him and be in touch with him all through the years. What all I learned and the skills I observed and gathered came to a great help when I started my first overseas project in a remote hospital in Ghana in West Africa, where I was on my own to deal with every surgical emergency which came through the door. I must thank Professor Vittal for that, and I pray Almighty to give him good health and great happiness all through for many, many years to come. Thank you, dear Professor Vittal. Have a nice evening with your friends.
When I had my birthday, he talked to me on the phone. Yeah, I was very happy to Amarendra has come up to accident and emergency consultant and so much. And it's a wonderful personality. He is also hardworking.
Yeah.
There is no substitute for hardworking in surgery.
You have taken the endocrinology as a super specialty now to the whole country, I think, and not only you established yourself, and I think everybody see you as a face of endocrine surgery in India, and you brought the super specialty and various colleges across the country. You went and motivated all the people to take up, and even in our state, people like Jyothiramalingam and all these great personalities, I'm sure you can tell better than me. And your son and daughter, both Sai and Vishnupriya, they're all now doing a wonderful work in this field. And I think the Indian Association of Endocrine Surgery, where you are the founder president from 1993 to 95. Now Sai just now has become the president, and he did a marvelous job conducting the virtual conference. I think these are making you rightly chosen as you are the father of the endocrine surgery as a field in India.
When I was a postgraduate, those days there is recent advances in surgery edited by Selwyn Taylor.
Yeah.
He will always write about the thyroid and parathyroid. I used to read that. And R.B. Welbaum, who write all the time about the adrenal gland. So in my mind, I thought, why not? We also can go in that direction. Why should we not think about specializing in that? Well, lots of people, many people will say, after all, there is nothing there. No, that is different. But I thought if you narrow down your specialty, you widen your skill, is my axiom. Nobody can prevent, general surgeon by definition, as far as I'm concerned, he can do anything. He can do the thoracotomy, he can do laparotomy, he can do colorectal. Anything can be done. You can't say colorectal should not be. No, they will do it. So that is how I view that. So let them do it. Why not? Let them also do it. I'll also do it. Let me show that I will do it with little more perfection. That's all.
I think you made it, in the right time, because now if you see, even the super specialty endocrine, now people only focus on thyroid. Even in thyroid, they can focus on robotic thyroid, or they do. See, expansion is so much. I think one cannot master of everything. You need to focus. That is the only way to get the excellence. The excellence is only by a focused, concerted effort. I think you rightly chosen the field, sir, and you persevered. And I think that's the reason there are a lot of people now out there. Like you see, there are so many endocrine surgeons. They're very, very happy. And under your banyan tree, I think there are so many people here.
Well, throughout India, lots of endocrine surgeons, and particularly at the beginning of MCH in Madras Medical College, MCH at the HEPJ, MCH at the CMG. Lots of people are coming out as endocrine, and I'm very happy.
Your contribution in the Association of Surgeons of India, its growth. You worked as a honorary secretary for nearly 4 years and president of ASI 1998. The building we are seeing right here, I think it is with us in the ASI because of your perseverance and hard work and understanding with the Professor Rangabhashyam, people like him. And I think you need to tell something about the ASI and its role, because they rightly obviously chosen as the Lifetime Achievement Award for you in 2012. And we as a parent body, with the chapter of Tamil Nadu, we were very proud to appreciate all your thing, and all you can see, all these people, see how you can see Professor Mohan Prasad and Babu, and everybody is very happy to see you receiving this.
Well, I think at some time ASA was in great trouble because of the heavy loans that they had taken to build the auditorium. At that time only, I was brought in as an honorary secretary. Very tough time, really, because I had to manage a lot of things. By God's grace, I used to go and meet lots of people, bureaucrats, bank officials, politicians, everybody. And somehow I was able to get over the loans and turn the table towards the positive side. And that is how the ASA has started.
Two more jewels who came from your training. One, of course, is from Coimbatore. One of my close friend also, Professor Dr. Rajesa Bhavati, the consultant plastic and hand surgeon in Ganga Hospital. This is what he has to say about you. And
it's a privilege for me to speak about one of my mentors, Professor Vittal. I think if you think back and think about your teachers or how the world values surgeons, I think primarily the first criteria would be their skill levels. I think Professor Vittal was an extraordinarily skilled surgeon, be it when he operated on thyroid or parotid or abdominal emergency. I think his skill levels we found were extraordinarily good. And it's not that flashy operating or quick operating. And what really mattered was outcomes. I think his patients' outcomes were extraordinarily good. That's one. And secondly, he also taught us a lot of bedside manners as to how you deal with people, how you deal with difficult attenders. I think everything. So what we got trained was a wholesome training that we got from him, so which I am greatly indebted. The second point on which I would greatly value my association with Professor Vittal was, and when we were working as postgraduates, there's a time he started developing the surgical endocrinology division. It is only left for a few people to be pioneers and starting some subspecialties in surgery. I think Dr. Vittal was in the right time, and then he did a great job in starting the surgical endocrinology division. And trials and the tribulations that he underwent, it gave me a good idea as to if we could start up a microsurgery unit back in Coimbatore after our training. I think whenever we faced trials and tribulations, I said, okay, this is now. It's not that we are only suffering. I think everybody who has gone before us has suffered that. So for that, I'm eternally grateful to Dr. Vittal for the opportunity he gave when he was setting up a unit. That's the second thing. And the third thing that was I would value him is he served as an inspiration for the next generation. An inspiration in not only in teaching and in surgical craft, but also in attire and how you present yourself. I think that's all are very important. I value that, and I think they are very important. And they all know that was in good state when we went abroad and when we went to so many other units. What Dr. Vittal taught us was extremely useful. And the second thing I would be very happy in this part is that there will be a lot of good people, and you may be an assistant to them, you'll be working under them. That few people will be very happy, genuinely happy, allow you to grow. I think that's very important. I think that's a fantastic trait to have. I think that's what now we all remember. And he was very happy that to grow, because even when I was postgraduate, we used to take evening classes. He used to tell me, no, you have to take class like this. Both him and Sara were extremely happy at the growth of their postgraduates, their students. And for that, we are ever grateful, and that's a trait which we also thought we should imbibe and allow others to grow under us. That's it. And last but not the least, however good you may be, how powerful you may be, however contacts that you may have, I personally feel that one of the greatest lessons he taught to me was that you need to be God-fearing. You need to be accountable to somebody. I think you need to be accountable to somebody beyond you. I think he was extremely God-fearing, and we had to submit. I think we really used to submit ourselves to before the Almighty, and for that again, I am very grateful. I remember him almost every day, and all the students pray for his continued good health, and hope he continues to inspire us. Thank you so much, Srimati, for this great opportunity.
Raja was very close to me those days also. He's a very brilliant man. And he got the Junior BC award those days itself. Rajesa Bhavati is a really hard-working person. Today, I'm very happy that he is on the helm of affairs in hand surgery and managing a huge mammoth hospital, Ganga Hospital. And I'm very happy when I see. Well, I think again I am telling you, the teacher must be happy. When I go to that Sai Baba temple, I see that Ganga Hospital. I said, okay, this is Raja is there.
Good evening. Guru. In ancient Sanskrit, the word guru has got two parts, gu plus ru. Gu means darkness. Ru is one who destroys that darkness. And that is what Professor Padma Shri, Dr. Vittal has been for most of us. I have been fortunate to have a 40-year learning experience with this gentleman. Every one of you knows about his awesome technical skills. We have all been mesmerized by his riveting lectures. But I am fortunate to have known him as a man, a gentleman, a mentor, and a philosopher. In these 40 years, what I have learned, most importantly, from Professor Vittal, and which I believe young surgeons all over the world, especially in India, should learn, is to do good to all. He's a Sai Bhakt, and true to what his teachings are, he does only good to everybody, and I have seen that time and time and time again. To do good to all, to have jealousy to none at all. This is what our youngsters must learn. I would like to end up by saying that recently in our hospital in India, in Kilpok, we inaugurated 5 theatres, and one of the theatres is called the Professor Vittal or Professor SVL Theatre, with a small write-up about him.
That's what Raj had to say, sir.
I know Raj for, as he says, more than 40 years, and I'm always very happy. Whenever he has an effort, first time he'll go and come back and show me, sir, I got this effort. I got this effort. 4 times he got all the efforts is completed. I was very happy, very, very happy. And well, I think when he took to minimal access surgery and bariatric surgery, I used to enjoy his surgery, his lectures, and his multifaceted personality. That is another thing for me. He'll play guitar. He'll write his English poems so nicely. So I always feel that God has given him everything. And I am very happy to call Raj Kumar as one of my students.
I think you had, we were pleasantly happy to have you in 2 occasions, at least in Erode, sir, under my tenure as a ASI chairman there, once to visit to a hospital, to give a Doctor's Day speech, and also Teacher Award. And also other occasion is when I released my first book, a small little book, but a small step, those days, a handbook of surgery. Now, after that, with your blessings, we were able to come out with the art and science in endoscopy, pearls of wisdom, manual of advanced endoscopy. Now I'm writing a handbook of colonoscopy. So all because of the inspirational foreword you gave, and also the pat on the back, and always you are me, even a distant teacher, because I was not fortunate to train under you directly, but I was in Coimbatore all along. But I think I will recollect this, what Drona is doing and what Egalya is doing, something like that. I usually relate something like that. PC Roy Award, Padma Shri Award, all those things are recognition for your hard work you have done for several decades for the medical and surgical fraternity. And this is more recent award of Doctor of Science from the Dr. MGR Medical University, and you are the emeritus professor for this university since then. And we as a IAGES were thinking and how a thyroid surgery actually is one of our curriculum in our IAGES also, because now we are going into video assisted endoscopy. There are people in our association also doing a lot of laparoscopic work. Abhay Dalvi, Dr. Sivakumar, there are a lot of people taking up endoscopic work in a big way. And where do you think is the thyroid surgery or the endocrinology heading? And what is the role for minimal access surgeon in the field of endocrine world, sir? Your vision for the next few years.
The minimal access surgery has come in as a beginning. For instance, now today we say the minimal access surgery is the gold standard for adrenal surgery.
Yes, sir.
Of less than 6 centimeter or whatever it may be. So that is how we become. Now you have to know minimal access surgery if you want to do. If you want to do that, you have to have a basic training of minimal access surgery. The same thing, video assisted thyroid surgery and endoscopic thyroid surgery, all that will have its own day. So nobody stays. The world is rotating and we are also rotating, and we have to go with the world and learn more and more and more and more things. Don't be static. Don't ever be static. Progress is the way of human life. So I see a great chance for the minimal access surgery in endocrinology also. And I wish you all the best in IAGES to take it up on a big scale. I am blessed with a good family in the sense my wife always helped me right from the beginning when I was going all the time to UK, USA, Singapore, Malaysia, all that, those days I used to be traveling like that. She was very helpful. And when I came to this level, my son, Sai Krishna, has taken over, slowly taking over, and he has already taken over. And that's gratifying for me. Suppose, he is able to he is able to do everything. He is managing the hospital, he is managing everything. Everybody says, and some people come and say, sir, your son is like you only, sir. I said, why do you want to belittle him? I said, tell that he is much higher than me. So I am blessed with a son who is academically very excellent.
Yes, sir.
Perfection. I may not be that perfect. I don't know. You may be knowing all that. Sai Vishnu Priya is now assistant professor of surgery in Madras Medical College. She has finished her MCH and she has got a gold medal also. And she is also doing very well. And she is also a good technocrat. I used to see operating. I used to see Sai operating. And that is, you feel very happy. Though I don't tell them on the face, you are done, operated very well. No, I don't do that. Because that will dampen their interest. So today I am opening out because I'm blessed with this family. Let me hope that God continues to bless this family and all of you and to me also.
I think it's been very inspiring and educating for all of us to listen to you for so long. I think the day is not enough to know all about you and your career. I think your life itself is the lesson for all of us to get educated. And we wish you a happy, healthy life, and you please continue to inspire us and the surgical fraternity as a whole, sir. Thank you very much, sir. Thank you from IAGES and our president, Dr. Raman Goyal, and our founder president, Dr. Udwade, sir. Everybody will be very, very happy to listen to this interview, sir.
Thank you very much. Thank you very much.
Thank you, sir. Thank you. God bless you, sir.
Thank you, Ishwar sir. Thank you for bringing out the entire spectrum of contributions from Dr. Vittal, and it's more testimonials from the present day legends in various surgical specialties. It was a lot of learning for all of us. And I also wish Professor Vittal and their family all the very best, and with all the peace and success in their career. Ladies and gentlemen, now we move to the second component of the IAGES prime time. I could see the enthusiasm in listening to this program. I have more than 20 questions already in the chat box for the anti-reflux procedures. I could see so many people are waiting to listen to Professor Watson. I had the honor of visiting him as early as 2008 to learn anti-reflux operations. And we have the honor of hosting Professor David Watson. He is from Adelaide, and he heads the Department of Surgery, the surgical disciplines at Flinders University Hospital, Adelaide. And he currently is the secretary of the International Society for Diseases of the Esophagus. And yet another reason to be proud, none other than our vice president, or the president-elect, Professor Sunil D. Papat, is going to moderate the session. And Professor Watson shares his experience with more than 4,000 anti-reflux operations. Over to Dr. David Watson, please. Nathan.
Okay. Friends, good evening. It is my pride and pleasure to host you for yet another important edition of IAGES Prime Time. Today, we have two important personalities. One, our President-elect, Professor Sunil Papat, who is going to be the moderator for this evening's important pioneer talk from one of the legendary surgeons who has been a forgot legend for the past 5 decades of his surgical experience. None other than Professor David I. Watson. Professor Watson has dedicated his entire career to the development and perfection training of foregut surgery, and he has a large experience on anti-reflux operations. He had the blessing of getting trained by the world-renowned teachers, and he has been instrumental for the Australia and New Zealand clinical trial group, and his BOSS program contribution are commendable. And he has been taught and associated with world-renowned foregut surgeons. With that, now I request Professor Sunil Papat, our President-elect of the IAGES, to formally introduce the speaker for this evening. Professor Sunil, please.
Thank you, Dr. Kanagwal. Thank you, IAGES, for inviting me to IAGES Prime. This is a brand new program which has come out in the last few months. On this dais, I am very pleased to welcome Professor David Watson from Australia. Welcome, sir. Professor Watson is a very senior professor of surgery and head of surgery at Flinders University. He has a very special interest in foregut surgery. And as Dr. Kanagwal said, he has trained many students, many surgeons, and many colleagues like us over the last 3 to 5 decades. Foregut surgery has evolved over the last 3 decades in a speciality of its own. And there are surgeons across the world who have developed interest in foregut surgery. Today, we are going to talk about mainly the fundoplication surgery. And all of us are aware that over the last 5 decades, this particular surgery has interested many, many surgeons across the world. As Professor would tell you in his talk, we have all learned our lessons from the knowledge available in the books, from the publications, and from our own experience. And it is very aptly said that a wrongly done fundoplication is much worse than the actual symptoms of GERD. So today we need to learn from Professor Watson how to do foregut surgery in a proper manner so that we and our patients and the community at large gets benefited. IAGES is a 27-year-old association of more than 8,000 laparoscopic surgeons of India. IAGES has been doing a lot of pioneering fellowship programs over the last 20 years. IAGES has trained more than 3,000 surgeons in its various fellowship programs, such as basic or advanced. Professor Watson, you would be surprised that we are doing advanced laparoscopic surgery fellowship only in upper GI surgery since last couple of years. We are doing advanced laparoscopic surgery fellowships in bariatrics, in upper GI surgery, in colorectal surgery, in hernia surgery, in HPB surgery, and in a year or two, we are starting in oncologic surgery and also robotics. This year, because of the pandemic, everybody got affected, and similarly, the surgeons of India and IAGES also got affected. But under the dynamic leadership of our president, Dr. Raman Goel, we have started a lot of webinars and teaching programs on the digital platform. And I think we have done more than 50 digital programs till now since February onwards. So I'm very pleased and humbled to welcome Professor Watson on this dais. Professor Watson, over to you for your last 3 decades experience and learning of foregut surgery. Thank you very much, sir.
Okay. Well, thank you very much, Professor Popat and Dr. Kanagavel, for your very kind introduction. It's an honour to be able to speak to you and to your association in India. Unfortunately, because of COVID, we're all unable to travel, but hopefully sometime in the not too distant future, I can actually travel again and can get to India. So sure. Thank you for your introduction. I will try and share my screen. Okay. So hopefully you can see the screen. I was asked to talk about sort of experience with surgery for reflux, and what I wanted to do was perhaps talk about some of the things that we've learnt over the last 30 years. My experience in terms of laparoscopic fundoplication started in 1992 when I was a fellow at the Royal Adelaide Hospital with Professor Glyn Jamieson, and I started working with him after they had done some experiments using pigs to try and work out how to do anti-reflux surgery or fundoplication laparoscopically. And I missed the first 3 operations. They were done before I started, but from there on, I was involved in the development of this surgery. So I bring greetings from Adelaide. This is Adelaide, or the centre of Adelaide, which is a city in southern Australia, and you're all very welcome to come here once COVID's finished, because unfortunately the borders are shut. But one day they'll be open again, and Adelaide's a really great place to come to, especially in the spring and the autumn. Surgery for reflux. I think, taking this back to the basics, what we're trying to do with reflux surgery is to permanently eliminate reflux symptoms, and those symptoms typically are heartburn and regurgitation, or one of those two. There are some other symptoms, but I think the dominant symptoms tend to be heartburn and regurgitation. And at the same time as curing the patient of those symptoms, we don't want to give the patient any new problems. Specifically, we want to not leave the patient with difficulty swallowing, dysphagia, or flatulence, or an inability to belch, or any other problems. So it's a balance of fixing the problem and not creating new problems. Reflux surgery really started properly in 1956. So we're talking sort of 65 years ago, when Rudolf Nissan described his fundoplication, which is a 360-degree wrap of the stomach around the lower esophagus. But I think it was really in 1991 when the first laparoscopic fundoplications were performed that surgery for reflux suddenly became a lot more attractive, because no longer did you need to have your surgery done through an open thoracotomy or upper midline laparotomy, but this surgery could be done through 4 or 5 small incisions. Recovery was dramatically shortened, and the perception from the patients was that it was a much easier operation to undergo. And in our experience, once we'd worked out how to do these procedures laparoscopically, the actual demand for this surgery probably went up about 300%, which reflects perhaps an untapped demand prior to the laparoscopic era. And as on my title slide in the introduction, what I wanted to talk about was some of our experiences over the last 30 years. So we've been going for nearly 29 years. And I did a quick look at the number of cases on our database, and it's nearly 3,800 cases when I looked at this about 3 weeks ago, but we've done another probably 6 cases since then, and we'll be heading to close to 4,000 cases next year. Our caseload initially in the first sort of full year where we were doing things laparoscopically, we did just over 50 cases. But by the time we sort of got to about the year 1998 onwards, it's been pretty stable at around about 150 cases per year in our unit. So there's been as I said, a 300% increase in demand. The first procedure that we performed was the Nissan fundoplication, and this was the only procedure that we performed from 1991 to 1996. But we saw some early problems, and some of the early problems that we saw in the first few years and recognised, one of them was that we had a group of patients, probably about 10% of our patients, presented with an acute or early hiatus hernia. What we had been doing was trying to replicate the surgery we had done as an open surgical procedure, which was a fundoplication, and we would selectively repair the hiatus in patients who had a significant hiatus hernia, but we didn't do routine hiatal repair. We learnt fairly rapidly that this problem could be minimised if we always repaired the hiatus with sutures, even if there is no hiatus hernia present. We needed to put some restrictions on people working. We had some people that overdid the physical activity in the first few weeks and had acute hernias as a consequence, so we restrict people in terms of no heavy work for about a month. We also identified that most of these acute hernias occur in the immediate post-operative period. Sometimes they even develop in the recovery ward if the patient spends a lot of effort straining or coughing, or when they're not fully awake from the anaesthetic. So we've done a routine barium contrast swallow x-ray on the first post-operative day since 1995, and that identifies occasional asymptomatic hernias which can be repaired easily in the immediate post-operative period and reduces the risk of the problem. The other early problem we had, and I think this is potentially a technical error, but can occur if you get a lot of swelling at the gastroesophageal junction, and that is the patient that can't swallow. And this is a barium contrast x-ray where no contrast is going into the stomach. On day one, you actually probably don't need an x-ray to diagnose this because the patient literally can't swallow their saliva. And this is what we found in that particular patient when the patient was taken back to the operating theatre. So here's our esophageal hiatus with the esophagus going through it. There's actually a bit of space there, but all we did here was cut this single stitch, our top hiatal repair suture, check that our fundoplication was loose by lifting it up above the esophagus. And then on the next day, another x-ray done, and you can see the gastroesophageal junction is wide open and the patient can swallow. And the third error we identified early is what we termed a bilobed stomach, which is effectively an obstructed stomach where the error here occurred from only having access in some ways to 0-degree laparoscopes rather than 30-degree or angled laparoscopes in the early days. And we had a couple of patients where the surgeon took the body of the stomach rather than the fundus up to create the fundoplication. You can see it creates this two-chambered stomach. And in a very extreme case, this particular surgeon took the antrum up. So check what piece of stomach you're using if you're making a fundoplication. And this is a patient that's had a previous laparoscopic procedure done open, and you can see how the body of the stomach has been used to create the fundoplication, not the fundus. So we sort of became, I guess, acutely aware, particularly as we were doing more of these procedures, that the Nissan fundoplication is not a perfect operation. You can have problems with recurrent reflux in some individuals, and you can certainly have problems with side effects. Dysphagia is almost inevitable in the early postoperative period, but persists in a small group of people in the longer term. And then we have the additional problem of bloating and flatulence, which are related to not being able to belch and clear gas properly. And I think it's the side effects that create the problems that patients complain about after a Nissan fundoplication. So we set out to modify the technique to see if we could actually improve the operation to reduce the risk of side effects and still achieve good reflux control. A number of options were on the table. Various surgeons had advocated shortening the length of a Nissan fundoplication, making it looser, really loose and floppy around with a large bougie in the esophagus, dividing the short gastric blood vessels. So the North American surgeons strongly advised dividing short gastric blood vessels as a step to ensure that the fundoplication was sufficiently loose. And then the other option was a partial fundoplication, not wrapping the stomach the whole way around the esophagus. And this really was a modification that was advocated by some of the European surgeons going back into the 1970s and 1980s. So the question is, how can we best achieve long-term control of reflux symptoms? And how can we minimize the side effects following surgery? And is it possible to achieve a perfect outcome for everyone where we have excellent reflux control and no side effects? Now, I think it sort of depends a bit how you look at the problem, but if we consider this to be a picture of some surgeons who are up on top of the balcony and looking out on the world, and they have one particular view of the world and what it looks like, and maybe a particular view about how to do surgery for reflux. And then down the bottom, we have another group of surgeons, or I've used this photograph to perhaps highlight the differences between surgeons and gastroenterologists, but another perspective from down the bottom below the balcony. And both the people at the top and the people at the bottom think they understand the world and how things work. But when you put the whole picture together, sometimes it's not quite so simple, and none of us really get the big picture. We see our own perspective, and we struggle to see all the other perspectives and integrate them. And I think this illustrates why when we look at what we're doing for reflux, if we're changing what we do, we need to make valid comparisons between procedures. And to make valid comparisons, I would argue that we need well-constructed randomized controlled trials. And in this area of reflux surgery, we do have quite a number of randomized trials from which we can draw conclusions. If we don't run with evidence from randomized trials, we run the risk of bias, and particularly if you look at case series where the outcome has been determined by the surgeon, you can actually influence the outcome quite a lot by how you structure the questions and even who asks the questions. So our experience has been that if a surgeon asks a patient whether the operation's worked, they will are more likely to say yes than if someone who's perceived to be less directly involved, such as a sort of research nurse or even a gastroenterologist, asking the question. In the context of reflux surgery, there have been a number of questions addressed, and I'm not going to look at all of these because I won't have time, but essentially there are numerous trials looking at medical therapy versus surgery, and in general they show that surgery is at least as good as medication, if not better. There's been about a dozen trials of laparoscopic versus open fundoplication. They almost universally support laparoscopic as a better method than open. And there are some studies that have looked at the use of mesh in the context of large hiatus hernia repair, and they're a bit mixed, and that's really the topic for another talk and another day. But I think the mesh question is still controversial. If we're talking about surgery specifically for reflux, and we assume that the patient requires a laparoscopic fundoplication, I think the two big issues are whether or not to divide the short gastric blood vessels during Nissan fundoplication, or whether or not to do a partial fundoplication as opposed to a Nissan fundoplication to reduce the risk of side effects. So with the partial fundoplication, we've got the option of a posterior or toupee type procedure, or we have the option of an anterior procedure, and I'll talk about both of those. So if we look at the question of division of the short gastric blood vessels, there are 6 randomized controlled trials which have addressed this question, all in the context of Nissan fundoplication. They're listed there. I would argue that the better two are the one that we published from Adelaide, where we enrolled 102 patients and we've reported outcomes to 20 years. And the other study from Lars Lundell's group in Sweden, where a similar number, just under 100 patients, followed for 10 years. Meta-analyses of these trials basically show equivalent reflux control at anywhere from 1 to 20 years follow-up. These meta-analyses also show similar rates of dysphagia, and what I struggle to explain and even to understand why it should be is that in the larger trials, if the short gastric blood vessels are divided, you actually see more bloating and wind type symptoms after the vessels have been divided compared to an equivalent group where they weren't divided. We published a combined sort of meta-analysis. We basically took the data set from the Swedish trial and our own trial, and putting those two trials together, we had 201 patients, and we were able to combine the trials and look at outcomes at a mean of 11.5 years follow-up, so 10 to 12 years. And basically reflux control was similar, 82 and 89% in the two groups, not statistically significantly different. But that gives you a bit of a benchmark as to how effective these procedures are at 10 years as well, somewhere around roughly about 85% success in terms of reflux control. And these were dysphagia scores. So the columns on the right are where the vessels were not divided versus divided, and basically the dysphagia scores, or the number of people with mild, moderate and severe dysphagia, was not significantly different, and there was certainly no trend towards a better outcome if the vessels were divided. The significant issue was the bloating. So if the short gastric blood vessels were divided, 72% of the patients, of the 200 patients, reported bloating. If the vessels were not divided, it was 48%. Both groups had high rates of bloating, which is consistent with the Nissan procedure, but it was significantly worse if the short gastric vessels are divided. And we've hypothesized that maybe we've in some ways denervated the fundus of the stomach and changed gastric motility in some way by dividing those vessels at the original procedure. if we put all these studies together, 6 trials plus a meta-analysis, we would conclude that dividing the short gastric blood vessels during a Nissan fundoplication is not necessary. You just need to make the fundoplication short and loose. So how about a partial fundoplication? Well, a posterior partial fundoplication or toupee procedure is what you see on the diagram and also on this photograph here. That can be constructed quite easily. There have been 13 trials, some of these in the laparoscopic and some in the open era, 1,300 patients, follow-up ranging up to 20 years. Most of the follow-up sort of short to medium term, but a lot of trials that have addressed the question as to whether this is a better option than a Nissan fundoplication. And meta-analyses basically show good reflux control for both procedures with no differences. 11 of the 13 trials showed no difference for dysphagia, but a lot of these trials were, some of these trials at least were small numbers. That may account for some of that. There was less dysphagia after a posterior fundoplication at 2 years in a trial reported from Germany, from Zornig, so 8% versus 19%, and also a trial from Koch, another German trial with 100 patients. The consistent finding in these trials was that patients were able to belch more easily after a posterior partial fundoplication in most of the large trials, and inability to belch was 8% in the posterior group versus 16% in the Nissan group. So potentially less wind-related side effects after the partial fundoplication. The alternative is an anterior partial fundoplication, and this original concept was described by Dor from France, and is commonly used after a cardiomyotomy for achalasia as a way of controlling reflux but not causing dysphagia. So it's an attempt to create a more physiological barrier to reflux. So there are 2 ways of doing this. One is what we call an anterior 180-degree fundoplication. And in that one, the fundus of the stomach is sutured to the esophagus and the right side of the hiatus, the right hiatal pillar. And this other one here, which is a 90-degree partial fundoplication, the fundus is brought to the midline. So it really covers the left anterolateral aspect of the esophagus, and there's some bare esophagus between the edge of the fundoplication and the right pillar. When we do these procedures, essentially we need to dissect the hiatus, which is what you see on these pictures. We need to mobilize the esophagus and create a good retroesophageal window, and then put some sutures in to repair the hiatus posteriorly to stabilize the stomach and the abdomen. And then what we can do is we take the fundus of the stomach and slide it over the front of the esophagus. And we take a suture into the stomach and then into the esophagus on the side, and then the right hiatal pillar. And what that does is sutures, or basically stabilizes the esophagus and the abdomen, and accentuates the angle of Hiss and creates a flap valve to stop reflux. So this is our first suture in place. This is our second suture and third suture. 3 sutures holding the fundus of the stomach to the side of the esophagus and the right hiatal pillar. And then some additional sutures in the front to close off the potential space in front of the esophagus. And we end up with something that looks a bit like that, where the stomach's just being rotated or folded across the front of the esophagus. So there have been 5 randomized trials that have looked at this procedure. Of an anterior 180-degree fundoplication. We reported the first one. I'll show you some 20-year outcome data, which was presented at a meeting of the International Society of Diseases of the Esophagus last week, and is under review from one of the journals. This study from Bob Bakery from Cape Town, a slightly larger group, followed for 12 years, a group from China, and 2 small studies from Europe. What the meta-analyses and outcomes of these studies basically show is that from a dysphagia perspective, the anterior 180-degree fundoplication is associated with less dysphagia at the 1 year, 5 year, and 20-year follow-up points. The data at 10 years, which has been reported in 2 studies, actually didn't show much difference. But the 20-year data we've got does suggest less dysphagia at 20 years. Bloating is consistently less at all follow-up time points between 1 and 20 years after an anterior 180 fundoplication. Reflux symptom control in the randomized trials was equivalent at 1, 5, and 10 years, but at 20 years in our most recent study, patients had more reflux symptoms after the partial fundoplication. Equivalent acid exposure measured by pH monitoring at 6 to 12 months follow-up in these studies. Equivalent surgical revision rates at up to 20 years, but revision for different reasons. So this is some data we actually managed to get from our trial, a small number of patients to come back for a fairly detailed set of physiological studies at 14 years after randomization to anterior or Nissan fundoplication. Unfortunately, this is only 20% of the available patients studied, and the sample was biased towards the more symptomatic patients, but abnormal reflux in about half the anterior group, but only I think it was about 2 of the Nissan group. Lower esophageal sphincter pressures were comparable, but a little bit less after the anterior fundoplication. At 20 years, and we've recently we're in the process of trying to publish these outcomes. We started with 107 patients in our randomized trial. 15 people died across that 20-year period, which is perhaps not surprising since some people were in their sort of 60s or 70s when they had their original surgery. We had 4 people that could not contribute to follow-up because of dementia or a terminal illness in one patient. And we had 88 patients potentially available for follow-up and were able to determine clinical outcomes in 79. So roughly about 90% of that cohort. And these are the data. We measured heartburn using a 0 to 10 analog scale. So 0 is no heartburn and 10 is severe heartburn. So the mean score after the anterior 180 at 20 years was 3 versus 1.4 for the Nissan. This was better for the Nissan, less heartburn. PPI medication use, I would emphasize that not all patients taking PPIs are taking it for recurrent reflux, but nevertheless there is a difference here of 42% versus 17%, which is significant. And again, that is consistent with a better level of reflux control at 20 years after a Nissan fundoplication. If we look at side effects, this goes the other way. So dysphagia, again, on a 0 to 10 analog scale, where 0 is no dysphagia and 10 is severe dysphagia. Our mean score is 1.8 for anterior, 3.3 for Nissan, better after the anterior fundoplication. 1 versus 1.5 for liquid dysphagia, not significantly different. Bloating, 47% versus 61%, but didn't reach significance. Ability to belch, better preserved after the anterior fundoplication, 84 versus 66%. That was significantly different. And the other outcome we measured was a global outcome score. So really trying to integrate the reflux control with side effect issue to understand whether from the patient's perspective the operation was worth having done. So we asked the patients, did they think their original decision to have surgery was correct? Would they make the same decision again after the anterior 180? 95% actually said they thought their decision for an operation was correct. It was 85% for the Nissan. That was not significantly different, but you can see here that the poorer reflux control is probably being balanced by the lower rate of side effects to achieve a high rating. And not all people who were taking PPIs actually had symptoms. So for many of these patients, the PPIs were effectively controlling their reflux, whereas before their surgery, they were not controlling the reflux. So they ended up being happy with the overall outcome. The satisfaction score is on a 0 to 10 scale again, and this time 10 is the best you can possibly get, and we're 8.4 versus 8. So it was slightly, the trend was again in favour of the anterior, but no significant difference. And this is the surgical revisions at 20 years, or across 20 years. So for the anterior fundoplication group, there were 6 revision procedures, all for reflux. For the Nissan group, there was 1 for reflux, 5 for dysphagia, and 1 for hiatus hernia. So basically, the total reoperations were about the same, but the reason for the reoperations was different. It was dysphagia for the Nissan group and reflux for the partial fundoplication group. This is the study from Bob Bakery, published in the British Journal of Surgery. So they followed 163 patients for 12 years. They achieved 12-year follow-up in 90 patients, or 55% of their cohort. They saw no differences for heartburn, dysphagia, bloat, or bloating. PPI use was 29% in the partial group versus 8% in the Nissan group. That was similar, so different. The satisfaction rates were similar. So these are outcomes that are consistent with what we saw in our trial. Now, when we finished the recruitment and early data analysis for the anterior 180-degree trial, we hypothesized that maybe if we further reduce the extent of the fundoplication, we could further reduce the risk of side effects. So the anterior 180 was still had some side effects, but not as much as the Nissan. So we proposed this procedure, which we called an anterior 90-degree partial fundoplication. So basically what that involved was suturing the fundus of the stomach to the left side of the esophagus and the left hiatal pillar at the top, and then rolling the fundus across and stitching it to the apex of the hiatus and the anterior wall of the esophagus. So covering the left anterolateral aspect of the esophagus. And I won't go into as much detail as with the other procedure, but we did publish earlier this year in the British Journal of Surgery a combined data analysis of 2 randomized trials that we ran. So we ran one trial where the short gastric vessels were divided during the Nissan procedure and one where they weren't. We had 191 patients in these trials, and we had the opportunity to look at follow-up to 10 years. So again, similar scores to, and way of following the patients up to what I showed you for the previous trial. Heartburn score was trending higher after the anterior fundoplication group compared to Nissan. Didn't quite reach significance. PPI use was higher after the anterior compared to the Nissan, consistent with what we saw in the other trial. Dysphagia scores went the other way, so higher after Nissan fundoplication, consistent with the other trial. Painful swallowing, interestingly, was nearly 3 times higher after Nissan fundoplication. Satisfaction scores were similar. So this data is remarkably similar to the other trial that we ran. This slide is an attempt to try and summarize all of the randomized trials that have looked at the question of partial versus Nissan fundoplication. And essentially at sort of follow-up to about 10 years, anterior 180 versus Nissan, similar reflux control. Same with posterior, a bit worse after the anterior 90. Dysphagia, better after the anterior fundoplication options. Similar, except for 2 of 13 trials after the posterior fundoplication. Flatulence, bloating, inability to belch, all much less of a problem after the partial fundoplications, and overall satisfaction, sort of global outcome measures, were similar for all 3 partial fundoplication options versus Nissan. So we I guess our preference from this is we think probably the balance, if we're going to do a partial fundoplication, is at least in our hands towards the anterior 180-degree procedure. So I guess the question that you could ask after this is whether a perfect outcome is achievable for all patients after a laparoscopic fundoplication. So is there a perfect operation for the treatment of reflux? And I guess what I've shown you is the bottom line is no, there's not. There are trade-offs. There is a risk of recurrent reflux, and there is a risk of side effects. And I think we can consider these trade-offs as going across a spectrum. And if I construct my spectrum with Nissan fundoplication here at the top, going to a posterior partial, then an anterior 180-degree partial, then an anterior 90. As we go from Nissan to anterior 90, these side effects reduce. As we go from anterior 90 to Nissan, our reflux control becomes more secure. So there's a direct trade-off between reflux control and side effects, and they balance. And the question is, where does your patient fit in terms of this spectrum, and what are the issues that they prioritize when it comes to considering what type of operation to do? So I think if the aim of surgery is to maximize control of reflux, but at the same time minimize the risk of side effects, we need to consider that a partial fundoplication provides certainly early advantages in terms of reasonably good reflux control and minimal side effects compared to the Nissan fundoplication. And it does, I should say, it does actually remove from, at least from my practice, some of the quite severe early dysphagias that we used to see with some of the Nissan fundoplication group. This is a graph from a paper we published a decade ago now, but it does show across the first 2 decades of our experience that we started doing a lot of Nissan fundoplications. Then we started in really 1995 to 96 exploring the options of a partial fundoplication, particularly anterior. And as we became more confident with the results, we've ended up doing more and more partial fundoplications rather than Nissan fundoplications. And we've got a small cohort down the bottom who have a posterior fundoplication. So putting this together, considering this data and what we've learned over 30 years, the question is, what do I do? Well, I think, and I haven't really gone into how we do the first bit, but these patients need full workup. We need to basically make sure that the problem is reflux. And then we also need to consider, is the patient a high-risk patient? When I say high risk, I'm talking high risk not from a medical perspective of comorbidities. I'm talking high risk from the perspective of complaining about the outcome afterwards. So high risk of a poor outcome in our experience tends to be older women or people with atypical symptoms. They really complain about the side effects and will keep coming back to see us and wanting more and more things being done. So in the people that I think have a potential high risk of a poor outcome, I want to minimize the risk of side effects. I don't want to give them a new problem. Hopefully I've fixed their problem, but if I don't fix their problem because they've got atypical symptoms, at least I haven't given them a new problem. Lower risk patients tend to be in the younger age group. Men more so than women tend to fit into this group. People with typical reflux symptoms, so heartburn with at least some history of improvement with PPI medication or regurgitation. In this group, I explain the pros and cons of a Nissan versus a partial fundoplication, and I let the patient make a choice. If the patient can't make a choice, then my bias is towards a partial fundoplication. So what do I do from a practical perspective? I routinely repair the hiatus irrespective of what type of fundoplication. On the first postoperative day, as I talked earlier in the talk, I would routinely do a contrast swallow X-ray. And if I'm not happy with what I see, I will relook with a laparoscope if I'm concerned. I want to send that patient home knowing that I've correctly constructed the fundoplication and they've left hospital with a well-constructed operation. In terms of fundoplication type, we probably do about 80 to 90% anterior partial fundoplications now and about 10 to 20% Nissan once we work through the selection process. And I'll leave you with this picture from south of Adelaide, and wish you all well. Thank you.
Excellent talk, Professor Watson. I'm very privileged to be your first listener, along with Dr. Kanagwal, to this marvelous lecture. In the last few slides, you clarified most of the things what you actually do. Now, as I understand, you started with Nissans and now moved over to doing more and more partial fundoplication and particularly anterior partial fundoplication.
Yes.
So, just going back to the basics, in your clinic, in your practice, how do you get the patient for reflux surgery? Are they always referred by the physician colleague, or some of them land up on your OPD first and then you decide whether to do surgery or not?
Yeah, so they would come from different directions. So we would see some patients that come from the physicians, from the gastroenterologists. When we first started doing these procedures laparoscopically, interestingly, the view of the gastroenterologists were that a lot of patients had problems after a Nissan fundoplication. So patients heard that it could be done laparoscopically, and probably about half of our patients came from sort of family doctors, general practitioners. These days, I think it's probably about 2/3 come from the gastroenterologist and about 1/3 from the family doctors. I do my own endoscopy, so sometimes I will see people that are sort of undifferentiated reflux problem, and I'm quite happy to put them prescribe PPI medication and manage them that way. So I probably prescribe more PPIs than most gastroenterologists as well because of the nature of the practice.
Yeah, yeah. And I'm sure that you're doing a lot of research work, so doing a pH and manometry would be part of your routine protocols. Is that across your country, or what is the situation?
Yeah, so we have good access to pH and manometry, so it's not it's not difficult for us to get those tests done. So my routine workup, and I think probably the routine workup for most surgeons in Australia would be esophageal manometry as a minimum. If a patient has and the reason for esophageal manometry is that it picks up the occasional patient who actually has achalasia, and I've been surprised by some of the ones where we've picked them up. I think there are people that you would genuinely miss if you're not careful. pH studies, we wouldn't always do them. If someone has typical reflux symptoms, heartburn with some response to PPIs or a history of response to PPIs in the past, and they've got ulcerative esophagitis, so they've got endoscopic evidence of reflux, I think that's good enough. They've got reflux. If their endoscopy is relatively normal, then we would do a pH study to get some objective evidence of reflux. If the patient has atypical or sort of unusual symptoms, I would do a pH study because I'm interested in the potential correlation between the symptoms and the reflux events on that study.
Absolutely. In one of your slides, you showed in the comparison between partial and Nissan's fundoplication that acid exposure post-operatively is always more in partial fundoplication. So in your trial patients, would you do pH study pre-operatively also to know the baseline acid exposure?
Yeah, I didn't show that, but it's in the papers in the journals. So in the context of the trials, the baseline exposure was comparable in the two groups. I think the view we formed is that the Nissan fundoplication effectively provides an overcompetent valve. It's a sort of a super competent valve, whereas the partial fundoplications are aiming to create, if you like, a more physiological valve. And the question for the partial fundoplication really becomes, can it sort of hold up over a long enough period of time? I think what we've shown is there are some trade-offs. The reflux control is not as good over time, but we do have a significant cohort of patients in the partial fundoplication groups who, before surgery, had reflux symptoms that were not controllable with medication, have had a partial fundoplication, and some of them have developed further reflux, which is then controllable with PPI medication. So those patients actually tend to indicate that they're still happy with the operation, because what their aim is to be symptom free.
Yeah,
and they are symptom free with effectively a combination of therapies. Ideally, you'd like them to be symptom free without any medication, and that is at least still the majority. But the patient's perception around this is actually a little bit different, more nuanced than perhaps ours is at times.
absolutely. And I think you mentioned in your slide wonderfully well that find out the high risk patients from the viewpoint of what they want actually, rather than their actual pathology.
Yeah. So I think, in my mind, I'm trying to work out, is there a group that should be steered in one or other direction? In which case, I'll tell them this is how I think it should be done. But for a lot of people, I think they do have a choice, and for some, they will prioritise reflux control, and for some, they will prioritise minimising side effects, and that's their choice. And I think we work with them to try and deliver what better fits their aims, knowing that there's going to be a small group of people that the outcome's not going to be so good. So we want that if they do get that not so good outcome, then it's a bit, it's the better of two evils, if you like.
Yeah. Okay, now talking about revision surgery, Professor, when do you decide actually to reoperate on your previous fundoplication patient?
Okay, so I think I break this down into it depends on the indication or the reason. So if it's recurrent reflux, I guess clearly I want to make sure it is actually recurrent reflux. Not all patients who claim to have further reflux actually have it. So those patients need a full workup. So they will get a pH study, an endoscopy, manometry, and a barium meal X-ray. And if they indeed have recurrent reflux, then I would insist that they are treated with the PPI first. I'll be careful about dosing. I'll have them on high dose PPI because a revision procedure is not as simple as a first time round procedure, and the failure rate is higher. So I'll maximise the medical therapy first. If they fail on that, then I put an operation on the table and we talk about the advantages and disadvantages. If the problem is dysphagia, and that's become less of an issue for us because of our bias towards partial fundoplications, but if the problem is dysphagia after Nissan fundoplication, and I do get referred patients who've had a Nissan fundoplication elsewhere, if it's less than 12 months after the original procedure, I just wait. Time often helps. More than 12 months, and if it's troublesome, my preference these days is actually to use a 30mm diameter pneumatic balloon, the sort you would use for achalasia, and do an endoscopic dilatation with a large balloon. That probably solves the problem about maybe 70 to 80% of the time, in my experience. If you use just the bougie endoscopically, it's not good enough. It won't deal with it, but a large balloon often will. If that doesn't work, then I'm prepared to take them back. And if I take them back for another operation, I think you have to be aware there are sort of two potential problems that can cause dysphagia. One might be the fundoplication, in which case convert it to a partial. So that can be converted to a posterior or an anterior. It's actually easier to convert it to a posterior. That's what I tend to do for those. But the other thing I do is I check the esophageal hiatus. Sometimes that gets quite scarred, and the restriction is actually the hiatus rather than the fundoplication. So put a bougie down there. I'll dissect the anterior hiatus, and if it looks tight, then I will divide the hiatal rim sort of anterolaterally on the left side, and that opens it up a bit, tends to help. That usually resolves the problem. Third problem is hiatus hernia, and trying to emphasize early, a lot of these I think occur quite early. So, you know, I'm happy if I see something on day one, they're going back on day one, day two, and we'll fix that up, and that reduces the risk. But there's a small group that will develop a hiatus hernia again, and if they haven't got reflux and they haven't got dysphagia, I tend not to do anything. But if they've because they're not really at risk of volvulus or mechanical problems, but if it's associated with dysphagia or associated with reflux, then we'll fix that up in the same way as I've described.
Absolutely. You answered my next question also. I was just going to ask that sometimes post-Nissan fundoplication, we see patients where they have no reflux, but on endoscopy and on radiology investigation, you would see that there is some paraesophageal hiatal defect. And we tend to leave it alone because patient is not symptomatic.
Yeah.
And I think you agree to that.
Yeah, I agree with that. If they're not symptomatic, leave it alone.
Yeah. Now, you already briefly touched upon mesh. I will simply ask, when do you use mesh in your practice, and which mesh?
Yeah, okay. So, so mesh is a really interesting topic, and we've published the 5-year outcomes from a randomized trial recently in Annals of Surgery. And in that context, we looked at a posteriorly placed mesh. So we had patients that were at least 50% of the stomach was in the chest and the hiatus hernia. So these are really big hernias. We repaired the hiatus with sutures, and we then used an onlay of mesh posteriorly to reinforce that. We used 2 meshes. One was a non-absorbable lightweight mesh, which the particular brand was called Thai Mesh. It's essentially it was a titanium coated, very lightweight polypropylene mesh. And the other one was Surgisys, which was biological. What we showed at 5 years was really no difference in terms of outcome between mesh versus no mesh. Very similar results to what the North American Surgisys trial showed. So the North Americans have published a 5-year outcome. We had a 5-year outcome, and relatively high rates of very small hernias, 1 to 2 centimeters in length, up to 50% in our study. But in terms of significant hernias that cause symptoms, required intervention, I think the reoperation rate was about 5% across all groups. So we don't use mesh anymore. We have not seen any benefit from it in our trial, or indeed any other trial that's reported longer term outcomes. We're pretty careful to try and preserve the fascial coverings around the wide esophageal hiatus, because I think if you are not careful about preserving that, you can create a defect that's bigger than it needs to be. I do things like you can drop the insufflation pressure to take tension off as you repair the hiatus, but we've not regretted sticking to a sutured approach. If someone does have a problem, it's a relatively simple revision operation. Earlier this year, I had a patient who was had an operation done up in Queensland acutely, had a big piece of mesh put in and reherniated. They decided to manage the patient after the reherniation at 1 week, not by operating, but by putting an esophageal stent in. And then the patient got transferred down to us and couldn't eat anything. Long story short, the revision procedure to try and actually deal with that was incredibly difficult. We couldn't get the mesh out posteriorly. We took the mesh out anteriorly. She's still got part of her stomach in the chest, but at least she can eat. This was a frail woman in her 80s, but we have a group of esophageal surgeons that meet every 2 years for a meeting, and the final session at our meeting each time is an opportunity to share your worst case with your colleagues. And there's a trophy for the literally the worst case. Yeah. And about a decade ago, I think all of the cases being presented were mesh complications leading to esophagectomy.
Yeah.
So I'm not a great fan.
Absolutely. In our practice in giant paraesophageal hernias, when the defect is more than 6-7 centimeters or even 8 or 10 centimeters, we are using composite mesh with a gap in the center and gap anteriorly. And touch wood, in the short follow-up of 5 years, we have not come across complications yet. But you said it rightly: the longer the follow-up, you would see the complication. My question is, in a giant paraesophageal hernia, if you are not putting in a mesh, so you would need a larger relaxing incision.
No. This is where that's the Stephen Demeester approach, and I think if you're really careful to, we aim to keep our dissection sort of about 1 centimeter inside the sac, so that you always have good coverings of the hiatal pillars, and we're operating on 30 or 40 intrathoracic stomachs a year, so this is not an uncommon procedure for us. We just start suturing posteriorly, and in many of the patients it just comes together without much of a problem. Yeah. If we see tension, so we're using a Nathanson liver retractor, which provides a degree of abdominal wall lift at the same time, so we can drop our gas pressure down to 6 or 8 millimeters of mercury. And so I tend to, if I start seeing any tension, I just start dropping the pressure. Once you get down to 6 to 8 millimeters of mercury pressure, generally it comes together pretty well. Occasionally it doesn't, and then the hiatus takes almost a triangular configuration, and I put some sutures sort of anterolaterally on the left side, and I come at it from another direction to repair it. I'm happy to accept that I might get a small recurrent hernia. If I get a recurrent hernia of 1 to 2 centimeters in size, and the primary indication for the operation was sort of rotation, volvulus twisting of the stomach, that stomach's not going to twist. So I've actually solved that problem. But yeah, we've just not been happy with mesh complications, and I guess my thought is, if something goes wrong, I'm thinking about what the next operation is going to be.
Yeah. So it's better to be aware of the dangerous complications of surgery. That's wonderful. Now, this is a vast topic, and we can go on discussing for hours, Professor. We liked your experience and your training. This is a complex surgery in upper GI, in foregut surgeries. And many of your recurrences or redos you would be doing may be coming from junior colleagues who are enthusiastically doing very tight fundoplication. So how to treat junior surgeons properly in this? What are your guidance? What is your guidance regarding training?
Yeah. Okay. This may be where I think where our training environment is perhaps a little bit different to some other countries, and I think we're quite different to perhaps the situation in the United States, where there's a lot of people doing small numbers of fundoplications. For us, this has really become a subspecialty operation. So before laparoscopic surgery, every general surgeon might have done 3 or 4 of these operations a year. When we started doing them laparoscopically, it seemed they all started coming to the groups that were doing it laparoscopically, and they were largely within the larger sort of university teaching hospitals. I think for us now, we've got fairly well-established training pathways. So surgeons doing this work now, our junior colleagues will have done a 2-year upper GI fellowship, and will have been exposed to maybe sort of 30, 40, 50 of these operations they would have done personally during that training. So we think we've sort of can get them over those learning curve issues and deal with that. And generally they are working in hospitals where they're working in groups with senior colleagues as well to be supported. So I think that's probably where we've been lucky, and we've been able to maintain that. And we've also, even within my own state, it's probably a sort of small enough environment, well, small enough in population, not small enough in geography, but small enough to actually know people, and people will speak to each other and share their problems and work through things. But it would be unusual for someone to finish general surgical training and then try and do one of these procedures. They would go through a fellowship program now.
Yeah. Now, sir, would you be advising your junior colleagues to use a bougie of some size in their first 30, 40 surgeries or first 1 or 2 years of practice?
Yeah. So for a Nissan fundoplication, I would still use a bougie to calibrate that wrap. I have colleagues on my unit that would use a bougie for a partial fundoplication to calibrate the closure of the hiatus. I don't use a bougie. I have another colleague that measures it. He will get a grasping instrument, open the jaws, and measure it out. He's aiming for 2.5 centimeters. I think you need to do something to make sure that you don't make it too tight. So with a Nissan, I think I would definitely use a bougie for that as a way of ensuring that. With a partial, you can get away without it, but I think you just need to have some other strategy to make sure you don't make it too tight.
Bougie of 56 or a simple orogastric tube, or which one would you use?
The one in our theatre is a 52 French bougie, but I don't think it matters too much whether it's 50, 52, 56 or even 60. I think you just need to have it. I think they all get it roughly the same size.
Yeah.
I tell our trainees that they need to make it look about the same size as a 20-cent piece. So an Australian 20-cent coin is the perfect size for.
Yeah. In our experience, excuse me, we have seen some of our patients post-Nissan fundoplication. In their earlier post-operative period, 6 months to 12 months, they develop frequency of stools. So have you come across such a symptom?
Yeah, no, I've seen that. So I've always assumed that's due to damage to the vagus nerves. So I think potentially, I think we see it more commonly after the really big hiatus hernias, the intrathoracic stomach. So I think it's incredibly difficult to identify and protect the posterior vagus nerve, and the anterior vagus nerve can be damaged as well. So certainly seen a small number of people who've had quite severe diarrhea in the early period. I've managed them with things like loperamide to try and slow down the bowel actions for a while, and generally once they get past about 6 to 12 months, it seems to stop. So I think it's I think it does get better.
What I was thinking was, if we injure the vagus, the motility would be reduced rather than increased. So I couldn't explain why it was happening.
Well, you get this sort of post-vagotomy diarrhea, which is sort of almost like a dumping phenomenon. And I think I specifically warn people after the big hernias. I tell them they might be constipated, they might get diarrhea. I'm not sure which one you get. There is, we see this a bit. Because I treat esophageal cancer, we divide the vagus nerve quite a bit. So we do see it sometimes after esophagectomy. I think it probably is a dumping phenomenon. What we do see, though, is after vagotomy, over time, you get sort of recovery of or rebalancing, if you like, of intrinsic nerve function in the gut. So by the time you get to sort of 1.5 to 2.5 years, things like gastric emptying after vagotomy largely recovers. But my experience is the diarrhea issue tends to be after big hernias or revision surgery where the vagus nerve is at risk.
Yes, sir.
And it does recover.
Right. Yeah, it's always self-limiting. That's what we have observed.
Yeah.
Now, last question, sir, before we finish, is regarding gastric bypass. In your redo cases, when do you advise gastric bypass? Recurrent refluxes.
Yeah, no, it's a really good question. So I think it's a good question. I've also seen people get really offended when I've had a couple of people come to me because a colleague has told them they should have a gastric bypass, and they got quite offended by that. So I think so obviously a gastric bypass is actually quite a good anti-reflux operation because you've diverted all of the bile and almost all of the acid away from the esophagus. So it's in many ways it's actually a more reliable anti-reflux operation than a fundoplication. So I think if someone's had one failed operation and they're not obese, I would happily, I wouldn't even talk about a gastric bypass. If they've had a failed operation and they are actually morbidly obese and they meet the requirements for gastric bypass, I think you do need to at least put it on the table as an option for them to consider. I wouldn't twist their arm. I think it's up to the individual as to what they want. And I've seen people that would want to go that way and some that wouldn't. So if they've had multiple previous operations, so if they've had two failed fundoplications or 3 failed fundoplications, I would be effectively a gastric bypass as the old antrectomy and Roux-en-Y procedure, which was described for that scenario. So I'd be more likely to put that on the table. I'd just be concerned if the patient was not overweight. I don't think I'd be putting that one necessarily on the table.
Yeah.
But it certainly needs to be considered, and it's part of the toolkit for dealing with reflux.
Right. Thank you very much, Professor Watson, for wonderful learning experience we had with you. And we certainly hope that in future, in many of our fellowship programs and forthcoming conferences, we'd like you to have in person here in India with us. And thank you so much for this wonderful lecture and opportunity to discuss with you some of the questions and queries we are having. Thank you. Over to Dr. Kanagwal.
Okay, thank you. Pleasure.
Thank you, Professor Watson. Thank you, Professor Sunil Papat, sir, for a wonderful session. I think, as you rightly said, this is a a day long or a couple of days long procedure where we need to deliberate a lot. And it's been a lot of learning. Thank you, IAGES, for giving this opportunity for me to host both of the senior faculty here for our IAGES Prime. We look forward to meet you in one other session. Thank you.
Thank you, sir. Thank you.
Okay.
Dr. Raman Goel, please. Thank you, Dr. Sunil. Thank you, Dr. Watson, for making such a long list of questions covered up, and almost we got answered most of the important issues. I now take the privilege of inviting the president to give his comments before we close.
I think, Dr. Kanagwal, you need to take the questions also. I know I see so many of them are pending. So before you take the questions, thanks for inviting me to speak a few words. I think it had been a wonderful evening and a pleasure to listen to Professor Vittal initially being interviewed by our Honorary Secretary, Dr. Ishwamurthy. Professor Vittal is a pioneer, a legend in his own rights across the country. And it had been a privilege, my privilege, to meet him personally somewhere, I think, 2003 and 2004, when I was invited for the National Conference of Indian Association of Endocrine Surgery. And Dr. Sai Vittal was also there in Chennai. And that is the time when they discussed including bariatric surgery as part of the endocrine surgery. I think that's an ongoing discussion. But it's amazing how he has molded lives of so many of people across the country. And that is what we had envisaged, that IAGES Prime will bring the legends of surgery across the country. You know, it's not about legends of IAGES, it's legends of surgery who have contributed in teaching and developing the philosophy of surgery in this country. And Professor Vittal definitely belongs to that class, and it's an honor for IAGES to have him participate in this. And I thank Dr. Ishwamurthy for organizing and conducting this talk so beautifully. Friend, this talk will be available on the YouTube forever, and I hope that many more surgeons who have not been able to join today would take benefit of that. The second part of the IAGES Prime today with the Professor Watson was amazing, because I had been doing fundoplications for more than 25 years before I stopped doing them because I chose to do bariatric. But I still do it as part of bariatric surgery in many patients, because almost about 30% of our patients do end up with reflux disease, and we need to do a repair in those patients. And what he has spoken today is what we need to accept, that there are no black and whites in surgery. In many conferences across the country, young surgeons ask, why don't we give a definite answer to them? Why don't we give 1 or 2, 3? And what Professor Watson has shown today, for a procedure for fundoplication for reflux disease, that you always have a trade-off. You have a trade-off better results and more side effects. You have a trade-off inferior results and less side effects. So I think these gray zones are part of surgery, and they are never going to go away. And as the society, as a surgeon, we all need to grow, and we all need to accept them. I find these questions asked repeatedly in bariatric surgery to me now, as they were asked earlier for general surgery to me. And it's very difficult to say that, but what Dr. Watson has shown is amazing, because it's evidence-based. He has shown where partial anterior repair worked better in long term as far as side effects are concerned, but had inferior results in terms of reflux. So I think Dr. Sunil Popat, who is going to be the president very soon in next 3 to 4 months, who is going to occupy the chair that I am sitting on today, has done a wonderful job by asking such pertinent questions and bringing out the best out of Professor Watson. So thank you, Sunil, for taking this responsibility. And I again thank Dr. Kanagwal for conceptualizing this idea and conducting this meeting every fortnight. I know there are many questions. I can keep on talking, as everybody is saying, for 1 or 2 days only on reflux disease. But I leave it to Dr. Kanagvel to take your questions and to get their answers. Dr. Kanagvel, please.
Thank you, President, sir. In fact, it's 3 o'clock in the morning in Adelaide. So I would say, please mail us your questions. Professor Watson has agreed to get back with all the answers. So with that few words, I thank for the opportunity given by the IAGES. I thank the President, Secretary, and the entire EC for allowing me to conceptualize and do this program fortnight after fortnight. Now I formally invite our Honorary Secretary, Dr. Ishwar Murthy sir, to propose the vote of thanks. Over to you, Dr. Ishwar sir.
Thank you. Thank you, Mr. President, friends, and ladies and gentlemen. I think it's a very interesting blockbuster event and edition from our hero of today, Dr. Kanagvel. Well done, you have done laurels to our association on a festive weekend, I'm sure, with blessings of our Lord here, the Durga and also Saraswati. I think it symbolizes the knowledge and power, as you can see, the triumph of this event and celebrating the triumph of the good over evil. I think the tone is set for this very important blockbuster. Both the events were so wonderful. The one taken hour-long by our President-elect Sunil Papat, really choreography. I think I say the way he structured, the way the clarity of the message from David Watson across the other continent for nearly an hour is amazing. I think his pearls of wisdom after 4,000 plus surgery is amazing. I'm waiting to hear all the interactions going to happen. I think we need to allow them to watch this site in the next few days to see all the chat box filled with all the questions and answers from them. And well done, Kanagvel, for coordinating this event. And of course, my time, actually, it was a real moving time for me as an interviewer to talk to Professor Vittal and his family. I think that I have to thank the family for the time and efforts, because they gave me a lot of pictures and all the things, and I brought those 4 students only to set the storyline, how inspiratory and how stimulating to see a giant and how he is acknowledging all the good. So that's the thing we wanted to hear more and more in our forum. And we also recognized a lot of our IAGES members also being a part in various things. And before I go, I need to thank the team, Indo-UK Surgicon, and all the people out there who were delegates, 2,000 plus delegates who joined. Please watch me in this platform to reveal you the time and venue of our next big, even a grand event, the IAGES 2021 at Coimbatore. While you are waiting, I request all of you to take the online fellowship courses. Wait for your convocation. FIAG is online, EFH is online. Now, with a forget person, David Watson speaking, we are having actually just 4 days to go to open our falls upper GI online. So please join in a big number and patronize, and I'm sure your knowledge is power. And today is auspicious day, Vijay Dasami day, tomorrow. I think all of you please register for this. And once again, Docplexus, thank you, Kritika. Thank you, Surveys, Nick, the whole team. Wonderful job yet again. And full mark to Kanagvel and our president. Thank you all. Bye-bye now.